Please have a seat, settle down. We'll be starting the session. So we are starting with the breast session now. I hope everybody has the voting meters. Are they there on the table? Okay. And we are starting on time and we expect to finish on time also. So I hope everybody adheres to the timing. We'll be starting with the first session, which is a young triple-negative breast cancer panel discussion. And for this, we have our chairperson, Dr. Nita Nair here. Can I invite the moderator for the session, Dr. Nita Nair, please.
Thank you, Anupama. So at the outset, I think kudos to the organizers, great conference. It's been a fabulous one day for sure. Early morning for us all, and I'm going to take this opportunity to invite my panelists to join us. Most of them don't need an introduction. We're all fairly well versed with them, and most of them are stalwarts in their field. We'll start with Dr. Geeta, who's from Max Hospital, Delhi. She's a surgical oncologist and director of breast oncology with the Max Group. We have Nikhilesh Borkar joining us from HN Hospital in Mumbai. We have Dr. Varsha Haridas, who's a radiologist. Dr. Seema Gulia from Tata Memorial Center, who's a medical oncologist. Vikram Maya, who's a radiation oncologist. And Dr. Tanuja Sheth, who's a pathologist from Tata Memorial Center. And of course, our illustrious Dr. Nadhar, who is a genetic counselor and probably one of the most well-trained out of all of us. So this is a fairly simple topic as it sounds, young woman with triple-negative breast cancer. A lot of controversies in clinical work and the real-world scenario that we see. We're going to try and stick to time so our organizers are happy with us. And we'll start with the case history. So we have a 30-year-old girl, unmarried nulliparous lady, who presented to the clinic with history of a lump in the left breast since about 2 months. She has very significant family history, maternal aunt who had been treated at the age of 50, her mother having had breast cancer at 45, and a contralateral lesion then 5 years later at 50. On clinical examination, she has a 3-centimeter lump in the lower inner quadrant, a B-cup-sized breast, is an early breast cancer clinically with a mammogram that looks like that, with dense parenchyma, but a clearly visualized single lesion in the lower central, lower inner quadrant. So before we move forward and we take that, I'm going to open this to an audience poll. So we request you all to vote. They can start voting. All right, so our question is, do you always ask for an MRI in a diagnostic workup of a young lady with breast cancer? It's a simple question on yes or no. I can't even see the results. Sorry, I can't see the results very clearly, and that would help. Okay, so we've got, can't read the percentage on that, but we've got about 60% of the people saying no. So I'm going to open this to our surgeons to start with before I go to Dr. Varsha on this. So Geeta and Nikhilesh, what is your routine practice on this?
Okay. So if you ask me, in a young woman, that young, 30-year-old, I would definitely ask for an MRI because, you need to not just look at the current situation. One is to understand, of course, what is the extent of the disease in the breast and the contralateral breast also. But subsequently, suppose she's to go for neoadjuvant chemotherapy, which seems likely, and the tumor were to disappear, and then she were to come back and say, look, I want a breast conservation. Sometimes it can be a difficult ask if you do not know what it looked like earlier on. So I would definitely go for an MRI at the beginning.
So Nikhilesh, any contrary view on that?
No, I too agree. Below 35, I would probably go for MRI in all females. Above 35, if the breast is dense, I would ask for a MRI. Otherwise, not needed. Because chances of missing multicentric disease is also very high in young patients who are more likely to be BRCA positive or some other mutation.
So I would actually hold a slightly contrarian view to that, is I would still base it on clinico-radiological discordance. Just because she's young, if it wasn't a dense breast, one may not necessarily ask for an MR. You may use an adjunct like an ultrasound to it, but to say that for all young breasts, I would still say that I would do it based on a clinico-radiological discordance, which is probably what would happen in a case like this with a heterogeneously dense breast. So, Dr. Varsha, your comments on the inadequacies of a mammogram with that kind of a breast. And I'm just going to take it back a slide.
Yeah. So I can see that this is quite heterogeneously dense breast, but as we see that the lesion is very well seen. We also always do a multi-modality imaging, because whenever we have a dense breast, it's not just we are reporting on a mammogram. We are always going to take help of ultrasound. If on conventional imaging, if I'm very sure that, okay, this is a solitary lesion, there is no multifocal or multicentric disease, there is no element of DCIS, I'm quite sure on that. So I will discuss that with the surgeon, and probably in consensus, if the surgeon is happy, we will probably not do an MRI. But in a scenario like this where probably if I see anything suspicious, I want to rule out a multifocal or multicentric disease, even as you said that she'll probably go for a neoadjuvant chemotherapy, then maybe she'll opt for a BCS. In that case, if the surgeon wants to be very, very sure that there is no other multicentric or multifocal disease, I think MRI is also an option. And if it is available, if cost is not an issue, I think we can go for that. So that is my, it's always going to be tailor-made according to me.
So I would think that's absolutely fair. Also, the fact that she has significant family history, potentially has genetic mutations, I think that's what's probably going to inch us towards the MR more so than just the history. We've got enough evidence on MR in screening for the high-risk population, and I would urge you all to read this paper. It's a very well-written review on role of MRI in breast cancer management by Selvi and her group. There's a systematic review that's been published by Hosami's group in 2020, which talks about the role of preoperative MRI as a routine. Now, of course, yes, it does cover a large age group. The range is not just young women, but we do know from data that's available from randomized trials, there are pitfalls that happen. It does lead to additional biopsies and anxiety, and we would need to tailor-make that and do precision oncology, so to speak. Now, this young girl with her heterogeneously dense breasts, with the fact that she had family history, we did do an MR. Unfortunately, I don't have the images of that because it was not done at the Tata Hospital. It's an outside MR which we reviewed. It fortunately showed a single lesion, no additional surprises for us, but it did pick up an axillary node also, which we also then looked at on ultrasound, had a 5 mm cortex, so we did go ahead and FNA that, which came back as reactive lymphoid tissue. As is expected, we went ahead with a core biopsy. Not very surprising, she came back as IDC grade 3 triple negative cancer. And this is where we have multiple questions on understanding the various types of triple negatives. Most of us look at triple negative as, it's bad disease, she's a young girl, it's going to mean a lot of things. There's a very heterogeneous group of triple negatives, and I think we need to learn to look at triple negative as a part on that spectrum. They're not all the same, they behave differently, and I'm going to open the floor to Dr. Tanuja to tell us, all of us keep asking for TILs, and if anyone follows any of Shirin Loy's work, you'll hear something new every year from her on TILs. 1 year it's the thing to do, 1 year it's not the thing to do, and I think there's new evidence again in 2022 where she's quoted it for staging also now. So what is our clinical significance and relevance of TILs in the clinic?
So Nita, I'll also go back to a little bit to radiology thing that we discussed. So number one is TNBCs don't tend to be very multicentric. I think because as subgroups they are very well defined. So just a thought process that maybe picking up those background lesions is not a common problem in TNBC. It's more common with HER2 positive disease. Second thing is that the estimation, there is a MIB1 written, so never do a MIB1 in TNBC because it's going to be high, though there is evidence that MIB1 can be used to stratify, but the papers have not there's a cancer paper way back in, I think 17 or 18, where they have said that MIB1 can be used to stratify a response to chemotherapy. But that's not taken off very well. Second thing is the tumor infiltrating lymphocytes, on a core biopsy, it's very heterogeneous. So we have evaluated core versus excision. Unfortunately, in TNBC, the trend is to give chemotherapy. I'm sure we'll have the debate later on. So if there are many trials going on in Tata Hospital based on immunotherapies. So for that, we do TLs and thing. But there is a discordance between core biopsy TLs and the final excision TLs. I don't know whether post-chemotherapy it's a totally different scene, because chemotherapy incites a lot of immune cell response. So number one is we did a little retrospective analysis and TILs were found to be, this is way back in 2007 when everything came, and we realized that TILs are prognostic, as in they are associated with more complete responses, but they did not predict overall survival, and I think time and again things have shown us that. The interest in TILs is mainly because now of immune therapy. So TILs on core biopsies, there is almost a 30% discordance with the excision specimen in operable breast cancer in the post-chemotherapy. So you know that the tumor which is cold can become hot post-chemotherapy. Okay. So those situations do occur. But if I'm saying that parallel biopsies, if I take without chemotherapy, there's a 30% discordance, because core biopsy does not target the periphery of the lesion. It does not target everything. So that's number one. So estimation of TILs, not difficult. And actually, Shirin Loy's earlier paper said that you start from 10, 20, 30, 40. And she said 50% was the lymphocyte predominant group. And that seemed good for me, because 50% lymphocyte predominant is easily identifiable category. But in her latest paper in Nature, where she said that staging into AJCC, we had these AJCC weird groups where HER2 positives, if you're HER2 positive and you're receiving targeted therapy, even if you're stage 3, you became stage 1. So she's added a second angle to that. She said now if you have stage 2 and you have high TILs, you become stage 1. So, and she's had a whole lot of classification of hers coming up, and which is a Nature paper, and there she's taken a cutoff of 30%. So my only worry is that 30 and all is, see, there is a tumor dense, yes, all of us here can, even clinician surgeons can pick it up, but when it is this small increment, so 30 may become 40, 30 may become 20, same thing as MIB1 will happen. So I'm not looked at, but when I did with my student her thesis, I realized that we never could give a group like that. So we had 10 to 20, 20 to 40. So, you know, that was the group that was then agreeable amount, concordance occurred.
So I'm going to ask you this, would TILs be part of your report on a routine now?
So I do include TILs for the last 2 years, mainly because what happens is now PD-L1, there was a lot of this enthusiasm about SP142 Ventana. So I thought let us include it, because many times what happens, unless you put that word, it does not strike that this patient is, you know, a candidate for immune therapy. So I always like TILs, DELs, we always write in our report, even in a core biopsy, TILs, DELs, TILs moderate and TILs mild. So that we know which biopsy to pick up if we have to do immune testing, immune cell testing.
So Seema, I'm going to actually ask you this, is if you see a report which says TILs dense, is it going to change your management plan for a patient with who's technically resectable at the outset? Are you going to use that in your planning?
It is not going to affect my treatment planning, because in early settings, if we look at the trial results of Keynote 522, patients who were either PD-L1 positive or not positive, both had benefit with immunotherapy. Similarly, there are other new adjuvant trials where either atezolizumab or durvalumab was used, and they looked at the presence of TILs. So presence of TILs predicted a higher response with chemotherapy as well, even without chemotherapy. So as Dr. Tanuja said, it is prognostic of response.
So fair enough. So we've just added another prognostic marker into our armamentarium. I think we're going to confuse the AJCC furthermore, and I am not really clear with the current AJCC myself. I still struggle with it. I don't know how many of you all are able to use it easily, and I think we're only adding to it with the TILs and confusing the situation a little more. So like everybody says, we're making breast cancer tougher for people to turn around and say it's just breast cancer. So, like I said, there's a whole spectrum of triple-negative breast cancers. A lot of this is work that's happening in labs. We need to start looking at it clinically. You will see a lot of work coming up over the years over it from various centers, because this is what's prognosticating the various triple-negative cancers. It's what's dictating PAT-CR, it's what's dictating response to various treatment modalities, and that's where we're moving now. So, we've got a 30-year-old young lady. She's presented to the clinic with very significant family history. So I think this is the point at which one of our conversations is obviously going to be genetic testing, because you've got a lady with significant family history who's going to move into treatment modalities, and we're going to start with an audience poll on what type of test would you advise for this lady. Would it be a whole genome? Would it be specific SNPs or pre-optimized breast panels? So nobody wants to do the SNPs. Rima, this is going to come to you eventually. But we're looking at a large proportion of our audience asking for a whole genome panel. And Aparna, I'm going to open this to you on what do you think is the best way to move forward and how should we be counseling our patients?
Okay, so I kind of disagree with the audience. I would not be doing a whole genome sequencing. Whole genome sequencing essentially means you're looking at the introns and the exons, which means you're looking at the entire genetics of a human being. You're going to get you're going to be looking at some genes that are not actionable. Your VUS rates are going to be through the roof. So in my very humble opinion, I would not even do whole genome sequencing in a clinical setup as a standard. We do use it in research work. For our patient, I would be opting for a pre-optimized breast panel or one of those hereditary breast and ovarian cancer panels because of her family history. You've got a family history of breast cancer in her mother, her maternal aunt. So I would be comfortable going for an HBOC-specific panel for this particular patient. But I think family history is very, very important. While we tend to ask about the female members in our family, and we tend to forget the male. So when a woman walks in that young, I would also spend some time in understanding if there's anything from the paternal side, if there is any male member who has had even an enlarged prostate at a young age, something as simple as that. So a conversation around history is very important in understanding the panel, but for this patient, I'd be comfortable with a 12, 15 gene breast cancer.
Fair enough. So I'm actually going to pull in Rima into this conversation just because she's part of the genetic clinic at the Tata Memorial Center. What is the current policy that we follow and what are we being able to do for our patients? Sorry, can we turn that mic on, please?
Yeah, it's on. So I think our current policy is to offer the pre-optimized breast panel. So we do have a 26 gene panel that we are using. For patients
maybe move closer to the mic because I think, or the mic, the volume.
So if the patient is unable to pay, then it goes in for the specific SNP based on the geoethnic group that the patient walks in from. Apart from that, I think the pre-optimized breast panel, like she suggested, is what is the standard. And now that we do it in-house, I think it's fairly easier for our patients to also follow it up.
Thank you.
Yeah. So, and just one more comment. It's not just for a 30-year-old that we will ask male side history. We do it for all patients. So we ask every patient whether or not they have either on their maternal or paternal side anyone with cancer or anyone who's died young. So that's how we sort of tend to.
No, I agree with you. I was speaking specifically for this case.
So I'm actually going to ask you exactly this. Is you're going to see a lot of individuals having asked for either a whole genome panel or even on a pre-specified panel, you're going to see reports which come up with either non-actionable mutations or a VUS. How do we tackle that and the kind of anxiety that that's going to pick up? Because everything with the VUS today is that today it may not be pathogenic, 2 years from today it's going to probably look different. And you've effectively brought in a bunch of anxiety to that patient's life over and above the cancer diagnosis. So what is the approach in the clinic for that?
So I think this is one of the key reasons I think pre-test counseling is very, very important. Because when a patient is signing up for this test, you kind of pre-counsel them and tell them that these are the 3 possible results you could get. You could get a positive, which means that these are the genes we're looking at, this is the actionability of it, and it could potentially help you and the rest of the family, however, depending on the gene. In a negative report, again, you would be explaining to them up front that this is the possibility of this report coming and this is its implication. And this is the best time to sensitize them about a VUS. So we all have an idea as to what would be the approximate VUS percentage of the labs that we refer our patients to. And you need to sensitize a patient that this is a possible result that can come. So at that point, if I see a patient is extremely anxious in my clinic, I may not even recommend genetic testing at that point. I'd say just hold on, take this information, deal with it for some time, come to terms with the fact that you've been diagnosed with cancer. And then going forward, we can do genetic testing when they can actually understand and make a sensible, rational decision. That's in a pre-test scenario. That's the ideal scenario. Unfortunately, we see a lot of post-test more than pre-test because it's when that result comes, they come to us. In cases like that, it does become a little difficult sometimes to ease the tension, the anxiety around those results. And I think it's just sitting down, having a conversation, walking them through what the pros and cons of that VUS is. A lot of these germline VUSs do get classified as being benign. So while we don't tell them that's the more high likely probability, you have to look at the family history and give them a slight indication as to what, for a VUS case, I usually go back to the labs locally and internationally, number one, to check if they've done any sort of course segregation studies at their end, which could give me an idea as to what is the importance of that VUS. So when that patient is over there anxious, I have some sort of data, some sort of information when I'm counseling them to say, okay, this looks like it's heading towards being benign, or it's looking like it's going towards being a likely pathogenic. And then it allows me to give them a more educated response as to what that means to them. It is tough, but I think very slow, very gentle, addressing their fears and their feelings around what they feel with this test is more important than that result.
So I could not agree more. So I'm actually going to bring Geeta in on this. You've got a 30-year-old girl, she's young, she's got family history, she's unmarried. Now you're talking to her about genetic testing, you're going to talk to her about fertility preservation, you're going to talk to her about treatment options. How do we sequence this in terms of conversation in the clinic? Yeah.
So I believe, you have to be very, very conscious of the fact that this 30-year-old has been diagnosed with breast cancer, just as Aparna said. And you don't have to really crowd her with a lot of information. So once the diagnosis is made, you know that the staging, everything is all right, and now you want to talk to her about genetic counseling. So I keep saying to all those people who come to me with trying to sell genetic tests, I tell them that I would not write a genetic test. I would refer you to a genetic consultant, because that is the most important bit, because I dread to think what happens if there is a test that comes back as positive and the patient does not know what the implications of those tests are, and then she decides to sue these people big time. And that is a very, very likely possibility. I see that that possibility as very rife. But having said that, Aparna's breed of excellent genetic counselors don't exist. So obviously the onus falls upon the clinician to counsel, and when you double time, you're doing your clinical work and then you try to do that, you obviously don't possibly convey the kind of idea that you would want to and prepare the patient mentally for a negative or a positive test or a VUS as it may turn out to be. So that's the time. When the patient has come back with all the results, this is the time to talk about, now treatment is on the anvil. That is the time when you will say, we need to do these bits also. Whether it is fertility counseling or genetic counseling, both I would say should be placed on an even surface, because both those things matter. And then you have to respect the decision of the patient. And sometimes I think patients are so high-strung at that time and are not able to make very lucid decisions. That is when you should step in as a clinician and help them make that decision, because she's 30, at the age of 34, everything is looking nice and she wants to have a kid and you've not made those provisions. That's sad. And if you've not done a genetic counseling and told her that, she comes back with a mutation, and you've not discussed the various options, that's also sad. So, I think we need to change our conversation around it and ensure that the patient gets the right picture and participates in that discussion.
So I would think that that's what's really important is the primary care physician, whether it's the surgeon, whether it's the medical oncologist that's starting it, needs to play a very pivotal role in planning the conversation around all aspects of care, not just treatment and obvious in that, but also the genetic counseling, fertility-based concerns, so that we're able to do that at the outset because we need to look at this as long-term outcomes for our patients. So this is going to be the audience poll, which is going to be the next debate for the, 15 minutes that we have left, is how are we going to sequence treatment for this? You have a 30-year-old nulliparous early breast cancer who's triple negative. She's node negative, she's 3 centimeters, she's operable breast cancer, she's amenable to early breast conserving surgery, NACT versus upfront surgery. So we've had a whopping response of about 77% saying NACT. And I'm actually going to start with Seema on this before we move on to whether the surgeons are actually going to refer her to you all for medical oncology and NACT or not. But Seema, what's your take on this?
So in this patient, because she is young, triple negative, with a strong family history, I would prefer neoadjuvant chemotherapy for her, being 3 centimeter tumor, though node negative. Because if we give neoadjuvant chemotherapy...
Seema, into the mic. Oh, mic.
So if we are giving neoadjuvant chemotherapy first, we can modify her treatment in the adjuvant setting. And moreover, we will also get a prognostic information if she achieves pathological CR to the neoadjuvant therapy.
So are both our surgeons happy to send the patient across to medical oncology in this sort of situation and start NACT?
So in fact, I voted for NACT in this case. So it has to be a case-to-case basis. And you've been very clever to put it as 3.1 because I usually take 3 as my cutoff. But the thing is, she's got a very strong family history and the likelihood of her coming back with a mutation is very, very high. So my surgical plan will also differ once I know that she has a mutation. My conversation changes. I'll be talking about prophylactic surgeries and those bits. And, so this is the time. You're basically giving her a cooling off period because there's too much of information to process for a young 30-year-old. So put her through chemotherapy, get her to the genetic consulting bit and the test if she wants to, and then come back and have a discussion because you get that much of time to prepare her for whichever surgery that she opts for. So neoadjuvant for me too.
Nikhilesh, any contrarian opinion? You agree with that?
I would go for surgery first.
Fair enough. I'd like to hear your opinion on that for sure.
Because we have the Oxford review where they said when you do a breast conservation after chemotherapy, there is increased local recurrence rates. I agree with the advantages of NACT, especially if waiting time is there. Their TNBCs are usually with high Ki67. If the waiting is 1 month or 1.5 months for surgery, then I would prefer to give chemotherapy. But if the waiting is within 2 weeks, I would prefer to operate and be done with the surgery. Another advantage of surgery will be we are sure that the whole tumor has been excised because sometimes on MRI we may see a concentric response or a Swiss cheese pattern, and in Swiss cheese pattern even if we see on MRI, to surgically address that we have excised it completely is always going to be difficult. Third thing, if she wants to go for embryo preservation or oocyte preservation, chemotherapy won't give her time because it takes at least 2 or 3 cycles maybe of stimulation for her.
It's about 10 days now. So, things have changed. So just as we are evolving, I believe the fertility specialists are also evolving.
We've got a lot of fast protocols. We've got a lot of sort of, I forget what the right word is, but rapid sort of induction protocols where they're able to do it over 2 weeks. You don't always get a positive extraction in 2 weeks. She's a young girl. It's only going to be oocyte preservation that we're going to be able to do since she's unmarried. But what we need to understand, and the reason for this point is that there isn't a single answer of NACT for all TNBCs or operate all early breast cancers up front. And I think we have to be able to optimize that for each patient. If you're going to want to wait wait to discuss, like Geeta said, you want to discuss other prophylactic procedures, you want to give her time to have that conversation later, yes, fair enough, buy time, start with chemotherapy. If you're going to be able to want to start with neoadjuvant chemotherapy, please map the disease appropriately so we don't run into concerns later when we're ready to operate. You don't want to reach a situation where the patient, we're lucky at Tata to have an MDT, everybody sits down, we have the conversation together. You don't want to reach a situation where the patient went and saw the medical oncologist, the lymph node was not mapped, you didn't FNA the lymph node, you don't know whether that was positive or not. You then come back post-chemotherapy and say, now please go ahead and operate, and this patient's going to get suboptimal treatment beyond that. She may necessarily end up having complete axillary clearance just because that axilla was not staged. She may not have been mapped appropriately. Like Dr. Varsha said, we may have wanted an MR just for certain specific aspects, clinico-radiological discordance. That may not have been done previously, and then we're looking at concerns later. Every case, therefore, would need to be optimized, and I think a lot of the buzz for jump to the bandwagon of NACT started with the CreateX data. Now all of us know it, and we know the fact that it told us that a group that didn't achieve PCR, you give capecitabine, they have a disease-free survival benefit, they have an overall survival benefit. You've even got a lot of data which tells you that for the differentiated in terms of the non-responders versus responders. You have no clue, and in adjuvant, you give them either capecitabine or platinum or something else, they do better. So you've got a lot of data emerging, which is just adding in chemotherapy, does not necessarily have to be in pre-specified groups of responders versus not. It does not have to be in pre-specified groups of locally advanced versus early breast cancers, and I think we're moving towards more personalized therapies. We're going to see biomarkers come out to this, which will help us decide which patient we're able to take in which direction. I'm going to ask Seema, and then I'm actually going to open this out to Shona. So we've already got Shona. Now, as organizer, she gets to talk first. See, they switched off the mic, Shona.
Do you have a hand mic? हैंड मैक दे दीजिए ना.
So I just wanted to make a comment here. First of all, when we think of CreateX and the buzz that it created, we've got to remember it was a subgroup analysis in the triple negative, which was 280 odd patients, which did show that OS and EFS benefit. And subsequent studies like GuyCam and all were very confusing, and they weren't able to prove it. The other thing I would like to say is that yes, we do use it in practice because it's simple to give, but it's not without toxicity.
So that's exactly the point, is that what's your real world experience with using capecitabine full dose?
Full dose has been difficult. We use a 202, which most patients, and you know, women who are early breast cancer don't like to walk around with black hands and black feet, and that's really a problem. But one thing I'd like to say is that it also depends on the kind of response you had. So RCB1, I think, is very different from a RCB3, especially in triple negative. And RCB3s, after having given perhaps anthracycline, taxane with platinum, and it's very unlikely that a tablet of capecitabine is going to give you that kind of
extra
benefit.
difference.
And maybe it's an RCB1 where you just need a little more to push that patient into a better prognostic group and cover up that extra overall survival, that it makes more sense to use drugs like this.
So I would actually think that what ends up happening is that we've moved away from looking at PCR, and I think that's a very good point that Shona brought up, is we don't look at PCR now just as PCR versus residual disease with its conventional definitions. You need to start incorporating RCB into your reports. You need to get your pathologist to review it, because that's going to make a difference on what your next move is, what your next options are.
Rita, can I just say one
Yes,
thing?
ma'am.
So I don't think even RCB is the answer, because actually RCB, now the more we are going into chemotherapy, so RCB magnifies the tumor, in the sense that if I give you a report of RCB1, it could mean 1% tumor to 10% tumor, it will still be RCB1. But for you, it will make a difference, because 1% clearly is a very low tumor load. So in fact, one of our students just did, but she's not published it yet, that we just quantified the tumor response, keeping in mind the pre. See, RCB does not take into account the pre-chemo size. It only takes the, whatever you've seen on gross. So we decided, let us see if it's a 6 centimeter tumor and it's come down to 1 centimeter, that's a very good response. And just by using this, the node status, we could get a very significant survival benefit. But we've not yet crystallized the whole thing because we thought it's the tumor response and the node status that is ultimately. We also added LVI, but LVI didn't, because residual LVI is a disaster in TNBCs. If you see any tumor, which if you get a pathologist report of RCB1 in the form of LVI, it's as bad as RCB3. So all these things, need to be charted out. Unfortunately, RCB was not aimed at TNBC, it was aimed at everything else. So we need a residual disease cancer burden for TNBC separately because, as you said, it's not one entity, it's 5 more entities.
Correct.
So just to think that maybe RCB is also not the final answer.
Point taken. So I've just looked at the clock and unfortunately we've not even had have a conversation yet. So we're going to run through this. Not going to bring in conversation on Pembro because yes, the data is exciting. It looks like it's interesting, but we need to be a little realistic about the actual use that we have of it. Platinum has moved in a big way in triple negatives. This was a very interestingly, very well done actually, individual patient data meta-analysis that was published earlier this year, which talked about the use of platinum both in adjuvant or neoadjuvant. And I'm going to show you some unpublished data, which we hope to present later this year. We'll hopefully have Dr. Gupta presenting this at San Antonio this year. Our neoadjuvant study of addition of platinum into the armamentarium for triple negative breast cancers has shown a significant 5-year DFS and overall survival benefit, and it's higher among the younger patients than it is among the overall group. So this patient, of course, did receive neoadjuvant chemotherapy with us. She did not get platinum, but she was given paclitaxel with anthracyclines. She came back as BRCA positive, and we did have clinical CR or clinical radiological CR. So I'm just going to jump to the poll question on this is, are we willing to offer a BRCA positive patient breast conserving surgery, assuming she's amenable for BCS? So I think that that's self-explanatory, and I'm glad that that's the answer. We need to be very clear that it's not just the fact that she's BRCA positive, which is going to direct us to doing prophylactic surgeries and mastectomies. We need to understand that the risk is of a second cancer, the risk is of contralateral cancers, all of which will change over time when she survives this cancer, so to speak. So that conversation does not need to be immediate. That conversation can be at the completion of treatment. And of course, contralateral sides, anxiety related to that. She's a young lady. We've not offered an RRSO with that at present. Seema, just a couple of takes on adjuvant olaparib, the fact that she's come back as BRCA positive. I think it was very exciting data that came out from Andrew Tutt's group. So are we keen to try and offer it to all our BRCA positive patients?
So we need to remember one point in the Olympia trial, that patient who achieved pathological CR after neoadjuvant chemotherapy, those patients were not included in the Olympia trial. So if this patient has 3 centimeter tumor and she has achieved pathological CR, so such kind of patients were not included in the trial. So the DFS benefit which we see to the tune of 8% may not apply to her.
Fair enough. So I think that's an excellent take home is that rather than just jumping the gun and saying that, she's BRCA positive, olaparib is the adjuvant answer, that's what we need to move forward with. We have to go back to the trial and look at what the trial included, what the specific criteria for that patient was. So Vikram, just to bring you in on this is, assume she had a mastectomy, she was node negative to start with, she's complete pathological response, she was 3 centimeters node negative, her sentinel node post-chemo is also negative. What is our stand on offering PMRT to these patients?
Yeah, radiation in a PMRT setup in such a young lady who has got a grade 3 tumor would be recommended, and especially when it is a post-mastectomy. Of course, when there is a post-BCS, definitely radiation is a recommendation. But now the present scenario says that in general, if you're not talking about this case, any patient with a T1 tumor and who's having a central or a medial quadrant tumor and they have, it's a grade 3 and TNBC, one of the recommendation is radiation post-mastectomy.
So there is also that the NCCN has just added in regional nodal and IMLN into its armamentarium for all node-positive disease and all inner quadrant disease. And I think this came up in the NCCN earlier this month. So again, this lady is unmarried. Just a couple of points on this. The real-world experience with the panel on trying to offer her fertility preservation. There are a few things that I learned last year only, is the legal regulations on how she cannot have a fiancé or an unmarried spouse help her fertilize that embryo. There are legal implications to that, and it has to be a married spouse only. So with oocyte, we know that there are concerns. We know that it's not going to have the same uptake and the same results of a pregnancy. You have to be able to counsel your patients very appropriately for that. We did look at a survey. This is some unpublished data again from the Tata Memorial Center, 350 women. I'm just going to take you through a couple of very specific points in it. Even though we had a very high awareness of fertility among this group, and I think that the 74% is probably credit to our DMG, that the conversation happens with every patient in the clinic, that, you know, this is what the detrimental effect of chemo hormone is going to be. But the additional awareness on the options of fertility or the success rate of those techniques was extremely low, which tells you that a lot of these women weren't asking for the procedure. And of the women, and we had about 64 women who hadn't completed their family, and I think this is unique to our country, is that even at 30, even at 35, a lot of our women may have completed their family, and we're fortunate for that. But there will be a small group that will not have. And despite that, with those 64 women who had not completed their family, we found willingness for invasive reproductive procedures like extraction, embryo preservation, and then assisted reproduction was extremely low, and at about 26%. Part of this was cost, part of this was fear of invasive procedures, a lack of awareness or understanding of it. And this is where we're going to jump to just the last questions. One word from each panelist before we close is, what do you think we're able to take away from all the studies that we have? We've got pembrolizumab and olaparib being talked about. We've got fertility preservation that we're jumping around about. We talk about testing all our patients. What actually happens in a real-world clinic? We'll start with Aparna and then move up.
I think first of all is having a conversation about oncofertility. That's unfortunately not happening in our clinics. In cases like this, patients need to be counseled. If I look at this one being BRCA1 positive, BRCA1 positive patients have a higher susceptibility to premature ovarian insufficiency. So this is something that should be discussed and the patient should be counseled about. So pre-test counseling for me is extremely important in cases like this.
So Vikram, things that you come up with specific to real world versus that. We're going to literally take 1 minute.
Yeah, actually, the first thing, what usually if she's unmarried and nulliparous, obviously, so we will be discussing about the fertility preservation. And with respect to ovum preservation, of course, everything comes with a cost. So that has to be discussed with all of these patients who come across. And of course, the rest of the things with respect to platinum and olaparib, that the option has to be given and that has to be discussed in detail with the patient.
So Nikhilesh, how many of your patients are you able to refer for pembro or offer fertility preservation to? Is it something that happens to every patient in your clinic?
No.
So I think that's the biggest point, is that one, it's not just about cost in larger institutions, it's a real world situation. Cost is a factor, other concerns are a factor, and we need to be more aware of that. Geeta, last words.
Like I said, while there is de-escalation as far as surgery is concerned, there is a lot of escalation in the medical oncology space, but we need to be very, very cognizant of what can be offered. And sometimes, patients should not go home with the idea that, I'm not getting the best treatment. So we should be very careful about how we put it across to them and not make them feel bad that they're not able to afford a certain treatment, and so your outcome is going to be worse than somebody else's.
So Tanuja, Varsha madam, and Seema, any last words, and we're done.
So just one quick word, the TNBC should not be treated as one disease. We need to look at it separately. And I think I spoke to the doyens in these classifications, and they seem to make it more complex than simplify. But I think we need to simplify TNBC so that it's applicable. There's something called as a future trial. I'm not very sure whether they've published their result, but if that comes out, all of us will be forced to look at molecular classification.
Varsha madam and Seema, and we're really done.
Yeah, so I would just like to say that we are trying to, by imaging, also give little biomarkers and trying to see whether some tumor appearances will suggest whether this is going to respond to chemotherapy or not.
Absolutely. So we actually have a TNBC biomarker study, which we are hoping to be able to have out by the end of the year. Seema, last words.
On a cup of tea.
On the patient and... Thank you.
Thank you. Thank you, everyone.